Terrence McNally. Welcome to Freeform, a world that just might work. I'm going to be speaking today with Troy Brennan, professor at the Harvard T.H. Chan School of Public Health, former chief medical officer at CVS Health, about his latest book, Wonderful and Broken: The Complex Reality of Primary Care in the United States. On Freeform, we explore the lives, the work, the ideas of individuals that I suspect have pieces of the puzzle of a world that just might work. We look at politics, environment, economics, science, health, culture, all based on the fact that I believe we can do better, and I want to find out how. The show plays weekly on the Progressive Voices Network on TuneIn.com, and podcasts are available anytime, anywhere on Apple Podcasts, Spotify, most major podcast sites, and at my site, terrencemcnally.net, TERRENCEMCNALLY.net. In preparing for this conversation, I put the phrase "sad state of U.S. healthcare" in search, not AI, and one of the first links was to an article titled "U.S. Healthcare System is in Crisis" by James LCMD on the website of the American College of Surgeons. And remember, surgeons are among the ones who do well in the current system. Some of his carefully footnote evidence: World Health Organization metrics rank the U.S. 37th overall to comparable Western countries and last among the 11 highest income countries. The U.S. healthcare delivery system consumes 17% of our current gross domestic product and is the leading cause of personal bankruptcy, accounting for 2 out of 3 of every individual default. Compared to similar Western countries, the U.S. has the lowest life expectancy at birth, the highest reported maternal and infant mortality, highest hospitalization rate from preventable causes, highest death rate for avoidable and treatable conditions, highest suicide rate, and highest chronic disease burden rate. Not only that, the U.S. healthcare system handicaps business competitiveness with a crippling 160% increase in employer healthcare costs in the last 20 years, which averages about $14,000 per employee. And this system naturally causes downward pressure on employee wages, resulting in a 9% inflation-adjusted decrease in employee household income. As Elsie puts it, we're spending more than any other civilized country in the world and getting worse results. No other known industry in a competitive or many non-competitive societies could survive by being twice as expensive while producing markedly inferior products, services, and results. In a recent Gallup poll, 3 in 10 adults said someone in their household skipped a recommended medical procedure, test, or evaluation in the past year because they could not afford it. 55% said long wait times for appointments delayed or even prevented their ability to get necessary health care. 26 million are uninsured, 43 million underinsured, and things are getting much worse. For the roughly 24 million people who get their insurance through the government's health care exchanges, Affordable Care Act subsidies expired at the end of last year, sending premiums soaring. Another 154 million people are insured through their employers, and premiums for those plans are also skyrocketing. As costs surge, even the companies and investors who profit from this business are now struggling financially. The U.S. accounts for roughly half presently of global health care spending, even though it amounts to 4% of the world's population. In 2017, the editor-in-chief of Kaiser Health News, Dr. Liz Rosenthal, argued that the American medical system has stopped focusing on health or even science. Instead, it tends more or less single-mindedly to its own profits. In 2020, the Nobel Prize-winning economist Angus Deaton argued U.S. healthcare is, quote unquote, a cancer at the heart of the economy. Angus was a guest in 2024, and you can find our conversation wherever you get these podcasts. So that's the big picture. Let's zero in on today's conversation. There is little argument with the understanding that primary care physicians play a pivotal role in both preventing disease and lowering health care costs at the point of illness. But these doctors are overworked, underpaid, and incentivized to move into higher paying specialties. while patients face provider shortages, and many actually live in ever-growing primary care deserts. So why is primary care underfunded and even more critically unattainable for many? Brennan lays out the steps and the hurdles in the healthcare system that conspire to produce the shortage of incentives and investments for the care that is our, excuse the pun, our primary relationship to our health for most of our lives. We're glad to have the specialists when we need them, but we all need them less if the US would prioritize delivering world-class primary care. How did we get here? In whose interest is it that we keep things the way they are? And finally, what would it take to adjust the incentives throughout the healthcare system so that they truly promote care for the health of individuals and society, with robust primary care a central piece of such a system? Troy Brennan is an adjunct professor of health policy and management at the Harvard T.H. Chan School of Public Health, a former professor of medicine at Harvard Medical School, former president and CEO of Brigham and Women's Physicians Organization, former chief medical officer at CVS Health and Aetna Inc. He received his MD and his MPH degrees from Yale Medical School and his, get this, JD degree from Yale Law School. He also has a master's degree from Oxford University, where he was a Rhodes Scholar. He's a member of the Institute of Medicine of the National Academy of Sciences and the author of The Transformation of American Health Insurance on the Path to Medicare for All, Just Doctoring, Medical Ethics in the Liberal State, and his latest, the one we're focusing on today, Wonderful and Broken, The Complex Reality of Primary Care in the United States. Welcome, Troy Brennan, to Freeform, a World That Just Might Work.
Thank you for having me, Terrence.
And let me tell listeners, we're recording this conversation Wednesday, March 11th, 2026. Troy, I'd like listeners to get a feel for the people behind the work and the ideas that we talk about. So in your own words, how do you see your path to the work you do, the life you lead? And feel free to go way back: mentors, turning points, childhood inspirations.
Well, I don't know if I go that far back.
Yeah, you don't have to, but some people do.
I always wanted to be involved in development of health policy and try to make a systematic change in our healthcare systems. And I pursued, a career that was focused on that. And I think I knew a lot of intelligent people and read a lot of intelligent things and tried to take appropriate actions based on that. And I have a lot of colleagues who did the same thing, and yet, as you've just discussed, you wouldn't say anything other than the fact that the American healthcare system has worsened over the course of the last 40 years. And those of us who are sort of toiling at that have some blame to shoulder, I believe. So where we went wrong, I think, is something that we should all be asking ourselves, and what we can do to sort of make it right. And since I left CVS, basically retired from CVS about 3 years ago, I've been doing mostly writing, as you suggested, and trying to sort of reflect on ways in which we should be thinking about how to improve our healthcare system. Because, as you said, we spend an awful lot of money in it, and we don't get the returns that we might expect.
Yeah, yeah. As I've said in that bio, you've played a role in many corners of the healthcare industry: physician, academic, executive. First of all, why did you move from one arena to another? Not all doctors do. And then what do you think that sort of wide-ranging career has shown you that you might not have seen otherwise?
Well, I was interested in change. So, as you suggested, when I first started my career, I was a primary care doctor, but I was also doing health policy research. So, we identified a series of different kinds of issues that we were interested in, myself and my research team, starting with sort of patient safety back 35 years ago, and then progressing through a variety of approaches towards how to improve care, quality improvement. And I slowly got involved in hospital administration and began to see that you could make changes in the way in which care was being elaborated insofar as you had leadership positions at hospitals. But then I'd say I became a professor at the medical school and the School of Public Health and the law school. at Harvard, and I had fairly senior executive jobs, but I got interested in working for insurers because I felt like the insurers had some levers that were unavailable to us who were on the healthcare provision side. And in particular, I was interested in how we were going to make our healthcare system more cost effective. And I thought the insurers could do that. So I went to work for Aetna, then for CVS Health, and then helped build CVS Health up into a, what I consider to be sort of a modern, some people would say vertically integrated healthcare corporation. That vertical integration gave us a lot of degrees of freedom in terms of things that we could try. And I think we did do some things that where we thought would improve healthcare. But overall, as I said, sort of having looking back on a sort of 40-year career, I'm not sure that we made all the right changes. And I think there's a lot more that needs to be done.
So for folks who may not even know that there's an entity like CVS Health, I remember when they went into that, when they made that shift from, I believe someone once told me, I think it stands for Consumer Value Store or something. It started as a very small little company of little stores, but I remember when they made that shift and said, we're going to also try to deliver some health care and we're going to insure. So for people who don't understand that, what was that and where does that fit sort of in the healthcare system these days, entities like CVS Health?
Well, as you suggested, it was originally a small retail pharmacy chain, and in fact, we always maintained a relatively sort of small company approach to things. I'd say we were headquartered in Woonsocket, Rhode Island, which was the original headquarters, and for a long time, the headquarters was above the one transportation center that we owned. But over time, and they became more interested, sort of how they could play a larger role in healthcare. And I joined just about that time when we bought a pharmacy benefit management company called Caremark. And then we began to develop community clinics, retail clinics in the stores called Minute Clinic. And the next obvious approaches to that integration, that vertical integration, was to get into the insurance business. So we bought Aetna, and then to begin to do more primary care. Because I always felt like, I think like a lot of people of my generation, if you looked at the appropriate approach to healthcare in the United States, it was probably a Kaiser model, where you were providing the care delivery, but also involved with the insurance. And I thought that CVS and other large insurers could play a similar role. And so that was the idea behind acquisition of and development of this much larger corporation. And it took a lot of time and effort and a good deal of money to accomplish that. And I think CVS is basically sort of still on that road of trying to figure out exactly how they use the resources associated with vertical integration to bring about better care and more effective care and less costly care.
So how would you kind of evaluate it at this point? Has it been successful, relatively successful, run into obstacles it hadn't, but or is that model gradually progressing in the right direction?
I think it's gradually progressing in the right direction. As to development of a huge primary care base at a retail, at a large corporation like that, I'm not sure that they're going to, sort of continue to build that out. And now I've been gone nearly 4 years, so I have no relationship with CVS anymore and don't own any stock, so I don't have any conflicts to talk about. But I think that it takes a real strong commitment. You see some of the other insurers maintaining that commitment. United Healthcare is one of them, Humana is another. And I think that there's still a great deal of appeal associated with having the primary care base and the insurance risk because that makes you focus then on primary care and on good primary care. And I think that good primary care is the one thing that's sort of lacking in our current healthcare system and the one thing that I think that can really try to bring us back. So that's the book that this we're talking about, the Wonderful and Broken book, is about how primary care develops from where it is today. But I would say, it's hard for corporations who have to sort of report on a quarterly basis, sort of what their profit and losses look like, to make long-term commitments, especially long-term commitments that might yield only over time. So it'll be very interesting to see how this sort of plays out with these large corporations having a role in primary care.
And you mentioned United Healthcare also has this vertical integration, right? And
Mhm.
I forget, is Optum still their chain, or have their chain of clinics? Or I heard there was even a new Express or Access or something. Where are they?
Yeah, they still refer to their clinics as Optum, and if you go to one of their clinics, it says Optum on the white coats and Optum on the big sign sort of out front. Optum refers to just about everything they do that's not the health insurance business. The United Health Group has a large United Healthcare, which is the insurance company, and then Optum, which does everything else, including a lot of data processing and a lot of other businesses. But a big part of it is their ambulatory surgical centers and their primary care. And their breadth there is significant in terms of their ongoing commitment to sort of own primary care. They've done a lot of it on the chassis of Medicare Advantage, taking care of people over the age of 65 and using their insurance product, the private insurance product, Medicare Advantage, that is the sort of twin of the traditional Medicare. And that's been an area where the government feels like it's been overpaying, has been cutting back somewhat. And so I think that's taken some of the wind out of the sails with regard to the sort of further development at United. But Humana has been at it for 2 decades as well.
I
And
didn't
has
realize that.
a primary care basis somewhere in between what United has and what CVS has at this point. So, as I said, looking at the development of primary care and these large insurance products like Medicare Advantage, it's a sinusoidal wave. And so you're sort of trying to avoid what you see as sort of immediate peaks and troughs in terms of the momentum around certain developments, and then trying to sort of predict more what's going to go on over a 15 to 20 year period of time. And so I'm relatively sort of optimistic because I don't see a different solution for
Mm,
our healthcare system other than one that has a strong primary care base. So, as a number of authors, it's been attributed to a number of authors, probably most frequently Winston Churchill. Americans will eventually get it right. They just have to try everything else first.
yep, yep. Let me ask you, just for folks to whom you are new, about your a couple of your other books, just to sort of, you know, give people a little more idea of your work. Just Doctoring, and you a quote I take from that one is, "Old ideas of physician beneficence and altruism must make way for a justice-based medical ethics." Why did you write that book, and what does it offer folks?
Well, I have to say, sort of my book writing has been sort of two different eras. I wrote about 3 or 4 books back in the 90s. I think Just Doctoring was published in 1992 or 1993. So it's an old book, but it was a book about the fact that the sort of ancient notions of medical ethics were that the doctor was selflessly sort of committed to the patient. And I think that still holds. That's still sort of a part of it. But I think that in that book, I was trying to express that there's also a sense that the patient has rights, and that we should be sort of respecting those rights, and that one of those rights is a right to health care. And so we need to be thinking about things not only from the point of view of the sort of individual interpersonal commitment between the doctor and the patient, but also the institutional values that were necessary to cultivate that and to make sure that that relationship could really work. So if you think about it, it's great to think, sort of doctors committed to patient, but if the doctor's committed to patient, doesn't that mean then that the doctor should be committed to universal access? Because you want every doctor to be able to be committed to that patient, and you want every patient to be able to have a doctor. So that was the thinking back then. But I must say, as I went into sort of first business in healthcare and working for hospitals and physician groups, and then over to the insurers, I didn't write books for years and years, mostly articles. So I've taken up book writing again now. Probably too late. I'm not sure anybody reads a book anymore, but I enjoy writing them. And so that's
Yeah.
what I'm basically on a sort of 3 book theme right now. The first
And I think the next one I'm gonna ask you about is probably one of those three books, which is The Transformation of American Health Insurance.
Yeah, so I try to set things up. That's the first book, and that was his book is based on sort of a historical read of what's been going on in American health insurance. And where there are sort of strong factors that are pushing us in a particular direction, what I call sort of the tectonic plates of healthcare, things like the fact that the costs are going up so much and the country's debt is increasing so much that eventually there has to be sort of a reckoning with regard to the nature of the system that we've built. Secondly, some things that are sort of more in the sort of inner workings of the insurance system. And I try to go into some detail to try to explain to people sort of how health insurance actually works. The book is meant to be read by sort of not the experts, but by an educated audience that's interested in how things actually sort of work. But I just see the chassis that we have right now, which is a lot of, it has a strong foundation in employer health insurance, is something that I don't think can persist. And so that's what that book is about. Basically, eventually we'll move towards some sort of government payer program, whether that involves private insurance companies, like is done in Germany and Switzerland, and is the way in which we operate Medicare Advantage, or a single payer like they have in Canada or the Great Britain, which is similar to our traditional Medicare. That's a matter of sort of how the politics develop. But I don't see how the government's going to be able to avoid long-term responsibility for the payment of health care.
Mm-hmm. And when you say the responsibility, so even so, in other words, in a Medicare Advantage plan, it could still be run by entities like insurance companies.
Yes.
So there would be a role for the private sector in delivery, but you do think that the payer of last resort will be the government.
Yes, and I'd say I try to be agnostic between sort of Medicare Advantage approach and a single payer approach. I think they both sort of have advantages associated with them. And I think that it's actually in many ways more practical to think about how you could get an evolution towards a Medicare Advantage based system as opposed to a single payer. But the point I try to make in the sort of underlying dynamic is that insurance companies for years had a series of sort of levers they could pull to try to reduce healthcare costs, and those are really no longer available. They're just not working well. And so the costs of employer-based insurance are going to continue to sort of go up, and that fire is fanned by the fact that the healthcare systems have a great deal of advantage with regard to sort of negotiation of contracts. So, right now, the average hospital is paid 2.5 to 3 times as much for the care of a commercially insured patient as compared to a Medicare patient, and 4 times as much or 5 times as much as a Medicaid patient. And that continues to grow, and you just can't see that continue to grow forever. Eventually, employers are going to look for relief, and they'll have to turn to the government for that relief.
Yeah, I think the and for those who don't know, um, the very fact that we have employer based healthcare is a fluke, an unintended consequence almost of World War II, right? We had wage and price controls, and we had millions of men serving in the services. So employers had a smaller base to draw from, and they needed incentives. Well, with those wage and price controls, they were handcuffed, and what they came up with was offering health insurance.
That's right.
And from that, set of of circumstances in that particular situation, here we are, um, almost, I mean, not a century, but 75, 80 years later, stuck with that system. Is there any other country that uses it?
Well, there is employer base elsewhere, and employers do get involved in sort of paying for the insurance. Germany is a good example. There's a whole series of private insurance companies. They're almost all nonprofit, but they then deal with employers, and there's a mandate that the employers provide health insurance. So, from the original sort of social welfare laws that went in place in Germany in the late 19th century, the sort of Bismarck inspired ones,
Right.
a lot of those were workplace based. So it's not atypical in Europe, for example, for the employers to sort of play a role. But the employers are not sort of directly relying on the insurance companies to negotiate rates and things like that. The systems, the degrees of responsibility between the employers and the government are much more oriented towards the government in those systems. And I'd say, the only way that we're going to get our healthcare costs under control is by the government basically determining what the rate of payment's going to be. In the United States, the government determines what doctors, hospitals, nursing homes pay, determines what the pay is going to be for those providers, and there's no negotiation, whereas the private employers have to negotiate. And as a result of that, since you don't feel like you're getting enough from the government, you're always going after the private employers for your wage increases. And that's become the sort of really only over the course of the past 30 years, the unfortunate dynamic, which is really making it more and more impossible for our employers to sort of keep up with the costs.
To some extent, you have said already that you think ultimately the government will take the ultimate responsibility. And yet, what you've just pointed out is that in those areas where the government is currently running things, Medicare, Medicare Advantage, Medicaid, and so on, their their authority and influence leads to a sort of a need for greed when it's not the government. And that just, I mean, just that alone says this is not a way to treat the health of our people.
Yeah. Yeah, you wouldn't, it's very hard. I go back to the sort of 35 years ago, the medical ethics book. It's impossible from a medical ethics point of view to say that, the care of somebody with Medicaid should be paid at a quarter or 20% of what the care for a person with commercial insurance should be. I mean, we couldn't possibly design a system like that today. It'd be considered inequitable even by the most far right person in the country. So, we've got a system that's grown and grown without sort of a close examination of exactly kind of what we're doing. And now, I must say, with the Affordable Care Act, the so-called Obamacare, did take a number of huge steps in terms of sort of fixing our healthcare system, especially with regard to access to care. And now that, unfortunately, in this administration is being cut back. So we're headed really in the wrong direction. You went through the sort of woes of the American healthcare system at the outset, but at least we were moving towards something that looked like universal access, and now we're clearly not.
Yeah, yeah. I've read interviews you've done where you've spoken about the effect of the Trump administration and RFK Jr. and so on, and you point out some good things because they're sort of not as tied to the status quo, but the benefits of those will be wiped out by the slashes to the subsidies, et cetera, in the big beautiful bill.
Yeah, that's exactly right. I like to say there, if we emphasize better diet, I'm not sure that they've always got the best definition of better diet. I'm not a beef tallow fan. But better diet, more exercise, preventive care, good preventive care, not preventive care that's based on recent whims or, unproven approaches. But
Or influencers.
right. But better preventive care, those things are all good. So there will be more people alive as a result of that. Unfortunately, almost all of that will be lost as a result of the changes that they're making solely in the environmental protection area. With regard to sort of increases in air pollution and exposure to other toxic substances, all of that will be wiped out. And then there's all the negative associated with taking health insurance away from people, which clearly harms health, and then people die. More people die than should. So, there are some positives, but they're unfortunately right now being outweighed by a lot of negatives.
Yeah, I hadn't even, I confess, although I have a big environmental bent, and if one looks at my archives, you'll certainly see that. I hadn't even considered their EPA changes. I mean, yeah, particulate matter, we've found more and more is probably, like ultra processed food.
That's
It's one of
right.
those, it's one of those things we've discovered has an influence we didn't realize, and an influence that's enormous. One, they're upset about. One, they're ignoring.
Yeah, and it's very unfortunate because Robert F. Kennedy Jr., for years worked and was supported by the Natural Resources Defense Council, and all of their work, has now been turned upside down by the current EPA.
I interviewed him when he was the head of Riverkeepers,
Exactly. Yeah. Yeah.
and I met him, and it was like, he was following in his father's footsteps.
Right.
It
Yep.
appeared.
Yep.
Let me tell people we're right at the halfway point. Let me tell folks, this is Freeform, a world that just might work. I'm Terrence McNally, and I'm speaking with Troy Brennan. He's a professor at the Harvard T.H. Chan School of Public Health and the former chief medical officer at CVS Health, and prior to that, a practicing primary care physician. And we're talking about his latest book, Wonderful and Broken: The Complex Reality of Primary Care in the U.S. Let's talk about Medicare Advantage. Now, I'm going to say a couple of things. One, for years, it was pushed hard by corporations. To me, nothing says fall besides as much as falling leaves and Joe Namath on television. Ubiquitous commercials. Check out your options. Check out your options. And whenever I hear check out your options, it means buy Medicare Advantage. Also in our mailboxes, one of my brothers retired recently from the direct mail business, and Medicare Advantage was his gravy train. It's like some people, you look, certain thing happens in a certain season, and that accounts for most of your profits. That's sort of where that business is. At the same time, most everyone I trusted in the healthcare space railed against Medicare Advantage as deeply flawed and almost a hoax and stealing people from real Medicare and that whole dynamic. And then I confess I was surprised to see that you uh, believe that even now, in some cases, it's playing an important role in moving us in the right direction, but that it can certainly do so moving forward. Talk a bit about, why it seems one way, why you see it another way, and what it will take to make it go in that right direction.
Well, I'd step back, and go, so historical approach is always good. And the government has, for years, pushed Medicare Advantage. But it goes up and down and depends on exactly sort of what the payment rates are going to sort of look like. I remember my first big meeting at Aetna with the senior team there when I arrived in 2006 or something like that. They were all congratulating themselves about getting out of Medicare Advantage
In
and
2006,
how stupid Humana was to stay in it. But because that was a period of time in which there had been sort of substantial cutbacks in rates of payment through Medicare Advantage. But most of that was changed by the Medicare Modernization Act in 2003, which also started the Medicare drug benefit. And, for years, Medicare Advantage was good business for insurers. I think the place where Medicare Advantage has really taken a black eye, and this has formed over the course of the last 6 to 8 years, is that there was a feeling that we were overpaying the Medicare Advantage. And I think that that's been well documented by the experts, in particular the Medicare so-called MedPAC, the assessment committee that sort of advises Congress about Medicare. And a lot of that was as a result of efforts to sort of change the coding. In other words, when you get a patient, if you think about Medicare Advantage is a capitated payment. So you're going to get paid $12,000, $15,000, $20,000 per year to take care of this individual patient. That has to take care of all their, if more is spent on that patient, then you lose money on that patient. So you get paid more if the patient's sicker. And in fee-for-service Medicare, there's no incentive to code the diagnoses that the patient has because there's no payment that returns from that. Whereas in Medicare Advantage, you do have an incentive to make sure you code all the diagnoses somebody has because that will increase the amount of money that is paid for that individual patient. And there was a feeling that there was a lot of gaming of that system. Probably to the extent, but it went up and down. In 2016 or 2015, 2016, we were paying about 3%. There was some sense that it
Did
went
you
to a
say,
sort
I didn't quite understand. Did you say we were overpaying by 3%?
overpaying Medicare Advantage by about 3%, but that there was at least a pathway to how it was going to be basically become even. But then I think that the insurers began to get better at coding and understood that there were incentives to do so. And like your brother, sort of, they were using his business because they had an incentive to sign up as many patients as possible. They also had an incentive to make sure that you coded as many diagnoses as possible. So I think that MedPAC would say that the coding got up to somewhere around 10%. But CMS has
Yeah,
made
but wait.
changes.
What you're saying is that what you had said before was prior, if you compared, it looked like Medicare Advantage was overpaying by 3%. And during this robust growth period, it got up to 10% more. That's a lot of
Yeah,
overpayment in a big
yes,
in what is about the biggest expense in the country.
right. And so, but CMS has made changes, and recent analyses of what the changes that CMS has made to try to cool down that coding suggests we may be headed back to sort of a 2 to 3% overcoding, and that there's other steps that they can take. The good thing from my point of view about Medicare Advantage is that the government has different levers or tools that it can use to change the nature of the sort of financial dynamics, and that's what I find sort of attractive about it. So it can be fixed. MedPAC also has concerns that that more healthy patients are going into Medicare Advantage, and less healthy patients into
Cherry
traditional
picking.
Medicare. But that's controversial. There's a lot of controversy sort of surrounding that. But from my point of view, at least, all these problems have sort of rational solutions that health policy people and health economists can come up with. And then from the point of view of working inside an insurance company, Medicare Advantage is much more heavily regulated. You're much more careful about what you do. The actual beneficiary gets a lot more attention, and I think it's a much better insurance policy than the average commercial policy is. That's a
Interesting.
perspective that doesn't come through at all because most people who are writing about this have never been inside an insurer.
Yeah,
So
that's right. You were saying not from our perspective, but from the perspective of the inside is where you saw those benefits.
right. And I think that there's obviously always other things you can do to sort of improve the quality of a health policy, insurance policy. But I think that the government was making sort of wise steps. Now, I can't say what's happened in the last year and a half because a lot of the people who were doing this really important work of overseeing these commercial insurers have left the Health and Human Services Department. I hope that it's still the case that there is this sort of broad oversight, but I can tell you for sure that you were much more careful about changes in the plan and the beneficiary's welfare in a Medicare Advantage plan than you are in commercial insurance.
Right, because your goal is to code as much as you can, but keep them healthy.
And the other thing, you do want to keep them healthy. And the other thing is you were heavily regulated.
Right,
Yeah,
right.
the government had very rational regulation in place, and has a series of sort of quality measures and safety measures that they can change and manipulate and pay on that create real incentives
So,
for.
given that the government has that kind of control, then one says, well, let's look at how these dynamics work. Um, when it gets into that 10% over and over coding and all of these things, um, is that because ultimately the government in a post Citizens United world listens to certain donors more than others?
Well, it may be, but I can tell you from the point of view of the corporation, it felt like strong external regulation. There wasn't a thought that, sort of if we just hire more lobbyists, we can get all this sort of watered down and not have to comply. That really was not the view. The view was that the government is very strong. The government can actually penalize me or take me out of this program completely. And I need to pay attention. And if the government was upset about something, everybody was upset, right up through the sort of CEO of the organization. So, um, there's no, I did write a long book with Don Berwick, another person very prominent in health policy in the late 1990s on regulation of healthcare. but I always had a strong respect for regulators. Got a lot stronger once I was in a regulated industry.
Uh-huh. Let me, one thing that is a sort of a belief or a myth of my own is that the biggest corporations in any field industry will fight regulation until it's inevitable, and then they'll write it. And the the example that I observed was landfills, and waste management. That other big one, I forget but the big companies fought regulation until it was inevitable, and then they wrote the regulations that were too strict for their small competitors to meet. Does that thing, does that same sort of syndrome happen in this arena?
Well, I'm sure there are people who could make out the case that that's happening. It didn't feel that way to me. And I would say, I can understand exactly sort of what you're saying about sort of landfills and waste management. And that regulatory capture is a real thing. There's no doubt about that. But I think with regard to Medicare, there was a good deal of concern about individual voters who are beneficiaries, Medicare recipients vote. And so I think the government had a special interest in making sure that programs that they were in charge of functioned well for individuals. So I don't think the average voter can get too into landfill
No, you're right. You're
regulations,
right.
but the
They
individual Medicare
they
recipient.
know their health, they know their bills,
Right.
and it's personal.
That's
Okay,
right.
and so the government has to. It's interesting. In that case, the government has to give extra weight to the actual American individual than
Yeah.
in certain other industries.
Yeah.
Wow. Um,
Yeah. And I say I'm sympathetic to the role of corporations in healthcare, a lot more sympathetic than almost everybody else who writes about sort of health policy.
it's true.
But I also
As
have a
someone who reads, I'll tell you it's true.
That's right. But I also have a very strong and healthy regard for appropriate and strong regulation. I don't, the reason why I think a Medicare Advantage program works well is because the government is capable of regulating and constructing the program such that it works for individual beneficiaries.
Yeah, and your hope in that it makes a positive contribution to the evolution in the direction we need to go, um, is that the government plays its role appropriately.
That's right.
Yeah,
That's right.
yeah. Let's move to this book specifically. And I recently was thinking about there's a practice in personal conversation which I'm usually happy when I employ, which is before speaking, ask myself, does this need to be said? Does it need to be said now? And does it need to be said by me? And it occurred to me that I'm interviewing authors all the time. It's a great set of criteria for a book. So in this case, Troy, this book, Wonderful and Broken, The Complex Reality of Primary Care in the US, what made you decide it needs to be said now and by you?
Well, what needs to be said, I think the one of the biggest sort of conundrums of American healthcare is the fact that everyone agrees, kind of around the world and in the United States in health policy, that you need a strong primary care base to have a well-functioning system. You want people to be taken care of, you want their conditions to be treated well, you want prevention to be applied, you want to avoid unnecessary care. And all for all that, you need a primary care base or foundation. And research has demonstrated in a variety of different ways, including sort of avoidable deaths and things like that, that a strong primary care system plays a really important role in terms of improving people's lives and preventing illness and death. So, but then everybody says that primary care is broken in the United States. So, you've already talked about how we seem to have a system that doesn't work well. Well, this seemed to me to be the greatest paradox. Everyone agrees that primary care is important. Everyone agrees that primary care is broken. And then, from my own point of view, I would say it is because this book and the previous one, the insurance book was sort of set up the theme. This book is a book about value-based care. Can primary care be the basis for a value-based system? I'm also writing a book now about cancer care, which is a fee for service, because I think that's the big tension in American healthcare between fee for service and value-based care. So the real question for me that didn't seem to have a good answer to it in the literature was, is there evidence that some primary care programs are developing and providing value-based care? And as a result of that, is the care better? And I knew it wouldn't be an empirical project, but rather had to be a project that was based on talking to people who were in primary care practices across the country. So it appealed to me because it got me out on the road to see a lot of different kinds of healthcare systems and primary care practices. And the conclusion I reach is things are moving in the right direction. There is at least a foundation for developing a new primary care that is value-based, and there's at least some incentives being set by state governments, federal governments, insurance companies, even private equity, that are driving in the right direction. But open question as to whether or not those incentives will be sufficient to really what I consider to be save primary care.
Okay, let me go back to one question that I meant to ask earlier, and then we're going to dig into this more, which is that from the press, from the mainstream media, it's my impression that you would think that Medicare for all, which you say is ultimately going to have to uh, save us, um, uh, is some extreme left idea of Bernie Sanders and AOC. When you, someone who's far from a wild-eyed radical, see it as ultimately necessary, and in some sense, anything that moves us there quicker, more efficiently, more effectively is the right move. And if it happens in 5 years instead of 10, we're better off. Um, why is there that disconnect?
In terms of
I
the
think public
disconnect.
perception and media perception and everything. It makes no sense to me as I watch it, and I've watched it, now for 50 years or something.
Right, right, right. I'm not, I think people both in the industry and generally sort of speaking, still will worry about sort of government being completely sort of, or healthcare being completely government run. What they don't realize is that if you go into the ICU I'm here in Boston, one of the major teaching hospitals here, 80% of the care is being provided, is being financed by the government between Medicare and Medicaid. And they are overwhelmingly the sort of largest payers. So I don't think they realize how close we are to a completely sort of federalized system anyway. And then secondly, Sanders, Warren, they're interested in a single payer program, and they'd like to shift over
Oh,
rapidly to a single payer program. And that's difficult. It's difficult to think about how that would be done. And they both build in. There's legislation written, and in Warren's view, it could be 2 years, and Sanders is 18 months. We take time to sort of but
transition.
hospitals aren't capable of doing that because the revenue streams would be affected sort of so radically, which is the reason why I like a sort of Medicare Advantage approach that allows you to do it on an incremental basis based on age. So you open up Medicare to under 60, under 55, under 50 over time, and you let corporations make a decision as to whether or not they want to buy a government program as opposed to what they're paying for from commercial insurers. So I think, sort of some of the big problems people see with single payer is how do you get from here to there, A, and B, they think it's a larger chasm than it is.
Okay, and so what gives you hope, and why you, because ultimately you're optimistic, hopeful, I think both those terms would apply, that we'll get to where we need to get to, and that there are pathways, whether through single payer or Medicare Advantage, and it's because you see it differently than people who don't pay as close attention.
Well, and I'm not necessarily on this, I don't have to be optimistic. I'm just looking at the trends, and eventually irresistible trends are irresistible. And
Optimism or not.
yeah, and even today, 85 to 90% of people in business say the government sooner or later is going to have to pay for healthcare.
Right.
So,
So
from them,
a
it's a
couple
reality.
a couple of terms you mentioned before, and I think the values-based one might be new to people. I want you to talk a bit about primary care and value-based care. How do you define them? What trends do you see? How are they related? And I think one thing that helps is if people when he says value-based care, you might have heard it 20 or 30 years ago as managed care. You might have heard it as capitated care. Tell us about those two, primary
Yeah.
care and values-based care, because I read one interview where someone said, you know, you say the book's about primary care, but really it's about value-based care. Go ahead.
Right, right. Well, I agree with you in terms of sort of, these are all sort of matters of terminology, and value-based care has been adopted over the course of the last 15 to 20 years because managed care got a bad experience. But the whole thing is, the big question is, should we pay people, I'll give you a certain amount of money to take care of this patient, make sure you keep this patient healthy, and reduce the cost to the greatest extent possible. And if you do that, you'll make a profit. Or do we pay you on a piece so that the more stuff you do, the more interventions you make, the more money you make? That latter is fee for service.
Unrelated to the health of the patient.
Yes, and so they both create economic incentives. It's just that the one allows you to sort of think about how you might control costs. The other doesn't allow you to control costs at all, fee for service. So I do create a tension between value-based and fee for service. And what I'm looking for in this book are places that are basically taking in some sort of set amount of money for primary care and then trying to spend that money rationally and take care of patients carefully so that you can make sure that they get all the care they need, but they don't get any unnecessary care. And there's a lot of different kinds of programs for doing that, and I do see value in those.
Let me just throw in right now. One thing you said a little bit earlier was that this book got you out. You saw programs, all of. So some of the good examples, some of what you think is working and why it's working.
Well, I went to a lot of different types of primary care practices, but I would say that the two that sort of come to mind. One is Native Alaskan practice in Anchorage, Alaska, where they take payment from the Indian Health Service and Medicaid, and they basically have a capitation as a result of that, and they take care of their patients with a team-based approach where there's community health workers, nurses, doctors, pharmacists, social workers, and they practice like a team, and they're able to support all of that because they get much better outcomes for their patients, and they're willing to sort of take extraordinary steps to make sure that there's community-based care and that people can stay at home and that they avoid unnecessary hospitalizations and unnecessary emergency room visits. So that particular practice, called South Central because it's oriented towards the South Central part of Alaska. Then I go all the way over to sort of Miami, where there's a set of practices that are run by a family. It's called the Chen family. It's a family business, but they operate clinics for patients who are relatively poor and have Medicare Advantage. And they take the same steps as are taken in Alaska, which is careful oversight of individual patients, team-based approach, lots of reliance on data, and a very supple electronic medical record. The thing that sort of distinguishes these kinds of practices from other practices is like in the morning, they have a team huddle,
That's I
and
was going to
all
ask
of
you about that.
this entire multi-specialty, interdisciplinary team gets together and they talk about here's our overall performance on our group of patients that we're taking care of, but then here's our 10 or 12 or 15 sickest patients. What steps do we need to be taking to make sure that we can promote their health? So that kind of team huddle, when I saw a team huddle, I realized I was in a place that was practicing value-based care.
Right. That in in practice, um, values-based care sort of needs that. It needs that communication. It needs, and one of the things you point out is in that meeting, it's like looking at these, our 10 or 12 folks we're talking about. How do we keep them out of the hospital? How do we get them healthy without having, because as soon as you walk the hospital door, your expenses are sort of, to most people, almost unfathomable.
Exactly. Yeah. Yeah. Yeah, no, it's prospective, it's anticipatory in a way that fee for service is retrospective and we'll deal with it after the fact. So, in a fee for service practice, you'll see 20 to 25 patients a day, and all you're trying to do is get them through in 15 minutes. And you're just driving along. Whereas in these practices, they have a much smaller patient panel. They take their time with the patient. The value is in assuring the patient's health, not in sort of like trying to plug the holes as the patient gets worse.
Right. Let me ask you one question and the final question because we've got about 3 or 4 minutes left. One is, where does this new concierge practice model fit in this? It seems to be happening a lot. My wife recently, that she changed doctors and that's what she went for. And then the last one is sort of, what should people do? What should they read? Kind of what would you tell people if they care about this going forward? So those two questions.
Yeah, well, the concierge thing is a matter of sort of like the average primary care practice is this miserable practice where you're seeing 20 patients a day and you're not getting paid very much. And so not many people are interested in doing that. So there's a lot of places in the United States where you just don't have primary care access. Your wife's probably like a lot of other people I know where their doctor retired and they couldn't find another primary care
Yeah.
patient, doctor, and so they had to go to a concierge practice. And from the provider's point of view, a concierge practice makes a lot of sense. If somebody pays 500, between 500 and $10,000 a year to join a concierge practice, that creates a tremendous windfall for the practice, and they can cut down their patients' panel size, and as a result, provide the kind of care that they want to provide. So, at the end of the book, I do look at unionization on the one hand and concierge care on the other as two potential poles where fee for service would drive us. I would hope we'd get to a managed care approach, and eventually, as the government begins to sort of have sort of stronger hands on the reins of overall healthcare financing, that they'll promote a primary care model that's based on a primary care capitated approach, and primary care doctors will find that to be a much more attractive approach. With regard to things to read, there's a coalition of primary care advocates that is constantly sort of putting out reports. And then the big thought leaders are really the people at the American Board of Family Medicine, the American Association of Family Medicine Doctors. They are very committed to a strong value-based future for primary care, and they are thinking critically about that. And they have a research institute that is constantly sort of developing sort of new plans, thoughts, approaches, which I think are very, very helpful. Robert Graham Center. So I think that the good thing is there's a lot of thought about how to improve primary care, and I'm at least partially optimistic.
Okay. Okay. Thank you so much, Troy. As I say, we got into the weeds a bit in things which I think normally people sort of surf over until it becomes critical for them and their family, and then they're behind the eight ball. The book is Wonderful and Broken: The Complex Reality of Primary Care in the United States. Quote, also, you'll learn a lot about values-based care if you read it. For this conversation and many other interviews and articles, to join me in pursuit of a world that just might work, go to terrencemcnally.net, TERRENCEMCNALLY.net, or a world that just might work.com, to the same website if you want to get my weekly email announcement telling you who's going to be on, what we're going to talk about, and links to 10 or 15 relevant and timely articles. Email me at TEMcnally, TEMCNALLY at mac.com. You can subscribe and listen to the Freeform podcast at my site or at all of those great podcast sites. You'll find years of podcasts there. I get these emails that say you have 721 podcasts in your archive. You could use our help to get seen by more people. There's a lot back there. It goes back to 1996, actually. Robert Reich, Van Jones, Bill McKibben, Tom Hartman, Doris Kearns Goodwin. Thanks to Kiana Williams in production, George Vasilopoulos at Progressive Voices, and most of all, you, my listeners, please share this podcast widely. And finally, thank you, Troy Brennan. Keep up your good work.
Thank you for having me, Terrence. I appreciate it.
Okay, thank you so much.